selection criteria. We have 17 minutes for each presentation. We would appreciate a 15-minute presentation and then a couple of minutes for comments and questions. Partha?
Thank you, Sanjeev. Thank you, Pepe, for the invitation. My disclosures here. So my talk is going to discuss initially the clinical risk stratification for TAVR, followed by the anatomical and hemodynamic selection criteria. I will go through the confirmation of hemodynamic severity using transthoracic echo, the criteria that's used therein. Then the use of CT and echo for really developing the structural geometry and analysis of the aortic valve and the root, and also some insight into the use of CT for vascular access and procedural planning. The clinical spectrum of aortic stenosis in the last several years has led to a starking realization that nearly 30 to 40% of the patients with aortic stenosis have remained unoperated in the past. And this particular gap in therapy for these patients has led to the evolution of transcatheter approaches. Over the last 10 years, we have seen the evolution of the field. Currently, the data that is available maximally has come from the Edwards Sapien valve and the Medtronic core valve. And currently, there are 3 other designs which have received approval in Europe. In the United States, we currently have the approval from the FDA for the use of Edwards Sapien valves, and data is being captured for the Medtronic valve. And the trials have utilized currently a systematic approach, which is called as the heart team approach, which involves essentially a team of interventional cardiologists and surgeons and imagers, along with social workers, who sit together for really understanding the risk stratification in a given case. Currently, it is mandatory that each and every patient that is discussed has considerations from an interventional cardiologist and 2 surgeons who go through the scenarios in a given case and use the risk stratification schemes. There are certain calculators that are currently available, which are the STS, which is used in the United States, and the Euroscore. And these calculators provide a multivariable algorithm to stratify the clinical risk. However, these calculators were developed essentially from patients who are surgical risk classified as low or intermediate risk, and therefore they may not essentially capture the scenarios in all situations, so it requires an individualized, personalized consideration in several patients. And these are the scenarios. You have low risk, intermediate risk, high risk, inoperable, and certain set of patients who would be considered futile for any therapeutic approach. And essentially, the role of TAVR has been currently established for patients who are considered inoperable or high risk. And there is certain trend currently to have a personalized discretion in certain cases with intermediate risk category where these may be useful. And what are these categories? When we talk about an inoperable patient, we are saying that they have a 50% or more risk of mortality or an irreversible clinical damage, morbidity like a stroke. And this was the criteria that has been utilized both in the US Sapien trial and is currently used also in the US core valve trial. And when you consider about a high-risk patient, there you're thinking about a mortality risk in excess of 15%. And you can use one of the guidelines, the STS score risk guidelines, and this risk currently is approximated to be high if it's more than 8%, 8 to 10%. There's been a variability because of the different type of the calculators, and for the rest of the world, this particular scenario may not completely apply. In the rest of the world, what has been utilized has been a Euroscore of more than 15. But there is also a presence of certain specific situation where a patient may be considered extreme risk or inoperable. For example, if the patient has cirrhosis, really poor lung function, previous CABG, particularly if the lima is crossing the midline and a surgical incision would not be possible. If there is pulmonary hypertension, porcelain aorta, severe right ventricular dysfunction, or history of previous mediastinal radiation therapy. So these particular individual scenarios are not captured in the risk calculators and can be used individually in a given case as a criteria for selection for TAVR. We now have seen the evolution of the field, and 8 societies have come together and provided a consensus statement, and the present consensus is that TAVR is considered a procedure of choice in patients with either extreme risk or high risk symptomatic aortic stenosis who are not suitable candidate, but they need to have at least survival of more than 1 year and fulfill some of the anatomical criteria which we'll be discussing. This is also the same criteria which was further elaborated in the consensus document talking about the prohibitive risk of more than 50% mortality expected in this group of patients, presence of frailty or specific conditions which will make it extremely difficult to have a reasonable outcome after surgery, or if the patient is considered as a high-risk surgical candidate, that should also be a reasonable criteria for electing for TAVR. There are certain specific exclusion criteria we have to really keep into consideration. For example, we do not have any available data that shows that patients benefit if they have either acute coronary insufficiency going on or really poor LV systolic dysfunction, severe pulmonary hypertension. Bicuspid aortic valve could be a problem because of the anatomical consideration and the bicuspid aortic aortopathy. If the patient has non-revascularized coronary artery disease, presence of excessive associated valvular lesion, or presence of HOCM. Similarly, presence of other systemic problems like severe renal dysfunction, presence of comorbidities, severe dementia, problems with the vascular access also make it challenging to consider for TAVR. There are also certain sets of patients where TAVR can create certain considerations, but these patients, we would not probably see them randomized in any particular trial. And the data is getting captured in registries. So as the registries evolve over time, we will know what exactly is the value. And these are patients with chronic renal disease who are on hemodialysis, degenerated surgical processes, where in fact we find a really good resolution of the process using TAVR. Patients with the new syndrome of low flow, low gradient aortic stenosis, or patients who may have treatable malignancy. In these particular situations, a center may enroll the patient while having the patient through a certain registry. So there could be situation in this subgroup of patients that one may be able to provide support in form of TAVR. So let's come to what's the imaging criteria for understanding the anatomical suitability for TAVR. Well, the presence of severe aortic stenosis as defined by the guidelines, valve area of less than 1 centimeter square, or a velocity of more than 4 meters square, or a mean gradient more than 40. And if the patient has a poor LV function, less than 40%, then you need to be able to demonstrate presence of a contractile reserve with a low-dose dobutamine stress echo. So transthoracic echo always is the first hemodynamic gatekeeper before you start the screening process for these group of patients. And then comes the sequence in which you want to know the suitability of the aortic annulus and the aortic root for a given process's design. And this is a recent review article that we wrote in JACC Imaging, which provides an algorithm. And when we talk about aortic annulus and the aortic root geometry, these are the specific things that we are looking into. We are looking into the aortic size, the annulus size, the leaflet geometry, the extent of calcification, the coronary ostia, the ascending aorta, and the LV outflow region. So the entire geometry of the subvalvular and the supravalvular region needs to be carefully assessed. And TAVR has really provided us a proper insight into understanding the aortic annulus. If you see the anatomical specimen shown here, you will see that the aortic leaflet joins the LV outflow region far lower than the anatomical ventricular arterial junction. And this incongruity of the location of the annulus attachment and the anatomical ventricular arterial junction requires very careful consideration. And the reason for this incongruity is because of the hinge point. The crescentic, the aortic valves have a hinge point which is far lower than the anatomical ventricular arterial junction. And this is the area, this is the virtual plane which you are interested when you are trying to look into the aortic annulus diameter. If you look into the anatomical junction, that may lead to overestimation of the aortic annulus geometry. We start with CT as the first step because CT provides very good spatial resolution into the geometry of the aortic valve, particularly in presence of calcification. And these are the views which provides us the understanding of the geometry, particularly the different locations and how this can lead to some errors in the assessment of the aortic annulus. So if you look into the trial leaflet, if you look into the hinge point on one side, the other side is not a hinge point. The other side goes through the commissure. So if you go to hinge direction as the measurement, that will lead to underappreciation of the aortic annulus diameter. Whereas if you go to the anatomical ventricular arterial junction, that can lead to a systematic overestimation of the annulus. And this particular consideration is extremely important when we are deriving the annulus geometry. So here you have the two planes, the coronal plane and the sagittal plane. And you can see here the planes, the two orthogonal planes are aligned initially so that they are coaxial with the aortic root. And subsequently, you have the transversal plane, and this transversal plane is currently going through the aortic leaflet, so this will be the valvular plane. And you need to bring this plane down till you have the point where you can see the hinge point touching the plane, and this is the annular plane. And in order to ensure that you're really going through the three hinge points, you'll have to subsequently go through a process in which you rotate the plane, the sagittal plane. So right now you have the right coronary hinge points being seen here, and you subsequently rotate it again, and you make sure that you have the hinge point going through the left coronary cusp, and then you further rotate till you get the non-coronary cusp. And once you have ensured that you have all the three hinge points that you have captured, then you can have the true annular plane or the virtual annular plane, because there is actually no anatomical plane. This is a virtual plane of the three hinge points that are being taken into consideration. You take the two diameters, the maximum and the minimum diameter, and average that to get the effective diameter. You can also calculate the area, because this area can provide you a better appreciation of the type of the average diameter that may be required, because the annular geometry is many a times not really circular. Most of the times it's oval, and it can be further distorted, and I'll show you some example. And you also take the perimeter into. So using this approach, you are fairly sure that now you have the virtual annular plane that has been captured, and you have some specific geometries that you can take into consideration. You're also equally interested in knowing the takeoff points of the coronary ostium. So you have the right coronary ostium. You want to make sure that you measure the length of the coronary ostium from the annular plane, and you have also to know the ostium of the left coronary and the length from the annular plane. And the considerations are that at least you should have 10 millimeter difference from the annular plane, because when you're going to go ahead and have a prosthesis, particularly the balloon expandable prosthesis, then if the length is lower than 10 millimeter, then there's a greater likelihood that you can end up with a coronary ostial occlusion. You're interested to also know and evaluate the extent of calcification, and whenever you are having calcific spurs, it's important that the annulus is measured outside the calcific spurs. So the calcific projections are included within this measurements, and the total quantity of calcification score has been shown to be useful because it's a predictor for paravalvular regurgitation. So understanding the distribution of the calcification is extremely useful to provide the operator the information that may be requisite for a proper device delivery and apposition. CT scan and angiography is also useful in providing insight into the calcification, tortuosity, and the luminal diameter of the vessels through which the systems are going to be approached. So here you can see this is a porcelain aorta, whereas you can see here in the same example, the common iliac vessel, the minimal diameter is only measured as 7.7 millimeter. And this particular diameter would be difficult to get negotiated with the 23 millimeter Edward Sapien valve, where the requirement are that you should at least have more than 8 millimeter minimal lumen diameter for having a proper entry of the device. So using this approach, you're able to really understand the type of the device and the kind of the negotiations that you might have to use in these situations. Wherever you may not have a site available for vascular access, you might have to keep consideration for a transapical or a direct aortic implantation for consideration for TAVRs. What about echocardiography? Now, in our center, transesophageal echocardiography is not routinely done in all cases during the screening process, but we do it specifically for patients wherever there are borderline situations and CT is providing some information and you're not really sure about what exactly the valve size is going to be required. And in such situations, whenever we do the annular measurements, definitely intraprocedurally, periprocedurally, just before the patient is getting the valve implanted. We go back and make sure that the annulus diameters are measured correctly. TE provides a dynamic environment and a dynamic annulus geometry. So this is useful for providing a complementary set of information. The biggest mistake that we see in TE that is done is when you measure the cross-sectional view. Remember that the cross-sectional view only provides one side going through the annulus hinge point and the other side going through the commissure. So if you have the hinge point here from the right coronary artery, the other side is not necessarily the hinge point, and it could be a higher plane because that's the level of the commissure. So you have to make the measurement not from this point to this point, but you have to go a little bit down somewhere here to really get the anatomical annular diameter calculated from the TEE. The advent of three-dimensional TEE has really provided more insights and providing more comparable results with CT scan. Here is an example demonstrated. So you have the 3D image which has been cropped in the 3-plane, and in this particular view you start off looking at the annulus. So this is the right coronary hinge point, and you are moving the right coronary hinge point, you're rotating this plane and trying to see the lowest point of the insertion to identify the hinge point. And then you keep on rotating, you're going through the commissure at this point, and then you go up into the left coronary, the cusp, the hinge point, identify the lowest point of the left coronary cusp, move it furthermore, go to the right, the non-coronary cusp, identify the lowermost portion of the attachment, and finally, once you have confirmed that you know exactly where you are having all the 3 annulus hinge points, then you bring the plane downwards, the transversal plane downwards, and then make the same measurements as you would do in a CT scan. This has provided some more congruity of information, and we now know that the annular geometry is quite elliptical, and single cross-sectional imaging views can really provide more erroneous results if care is not taken when measurements are done. So these are some of the standard recommendations that have been provided, and particularly in the gray zone area. So when you are trying to approach an annulus where there is 21 or 22 millimeters that's being mentioned by CT scan, in such situations sometimes I might get a call from my interventionalist that we might want to do the TEE, provided if there's also some kind of a difficulty with sizing, if the patient doesn't have an adequate vessel anatomy for a 23 versus a 26 valve, and in that situation you might do a TE up front and provide a little bit more confirmation of what could be the direction the interventionalist would take, whether you could safely do a 23 millimeter versus you will have to go over a separate approach like a transapical or a transaortic approach. Some of the borderline cases, therefore, provide us an opportunity for having multiple imaging modalities taken into considerations, and also we do the confirmation just immediately before the procedure is done. And these are some of the standardized recommendations for sizing we use for the core valve, which is undergoing a clinical trial in the United States. Now some more considerations about the annular shape and calcification. Using TEE, what we have recognized that it's quite dynamic to get some of this information, and this is the incremental value that you can provide during the procedure. Here you can see a patient who has got a really elliptical annulus and a lot of projecting calcific spurs. And these calcific spurs can lead to malalignment and subsequently be responsible for the development of paravalvular regurgitation. So understanding the geometry, the extent of calcification, the dynamicity of the annular motion is kind of important, and during the procedure, just before the procedure, to give some information to the interventionalist with regards to what kind of expectations we may have with occurrence of paravalvular regurgitations and whether there will be a need for a post-deployment dilatation. And the other reason why the calcium is a very dynamic and challenging situation is sometimes when you see this balloon valvuloplasty being performed, you see these calcific spurs like indenting and creating an atmosphere which will be prone to cause trauma. So understanding the definition and the location of the valvular calcification really therefore helps in giving a forecast of potential challenges that may be encountered, and this being the most catastrophic challenge, that's the annular rupture. And you can see here there's a VSD which has been created. There's an annular rupture which has happened because of an extensive calcification in this particular case. This is one more situation, and that's the evaluation of the left ventricular outflow tract. The LV outflow region may be very dynamic. In fact, many of these patients may present with a sigmoid septum with not really having gradients, not really having typical hokum-like appearance, but this particular shelf of LV outflows, which is projecting in the LV outflow, can create challenges. In this particular situation, for example, we knew that there was this outflow which was challenging, and here the ostium, which is really not a challenge with regards to selection of the balloon expandable stent.
You've gone over your time. Could you summarize now, please?
Yes. So here we will be able to see that with careful assessments, we'll be able to provide a dynamic environment. Here you have some vegetations which are also important to recognize for stroke, assessment of the ascending aorta, mobile structures which can be something like accessory mitral leaflet. And so to summarize, the heart team approach is really critical for risk estimation. Multimodality imaging is useful for securing the patient anatomical suitability, TE provides a dynamic environment. CT remains the gold standard for looking at the annulus size and the geometry, and echo is complementary for providing the hemodynamic information for procedural planning. Thank you.